welcome to Pediatric Grand Rounds. I have the pleasure today of introducing two speakers, Dr. Sarah Stewart and Dr. Mike Liu. I'll start with Dr. Stewart, who grew up in Seattle and has spent the last 12 years in the Bay Area, completing her undergraduate degree in materials science engineering, medical school, and pediatric residency at Stanford University. While in residency, she implemented changes to the electronic health record to improve the safety of medication administration by involving patients and their families. She is continuing to learn how to leverage technology to serve the pediatric population, empowering patients and their families to be involved in their child's medical care. She is currently a second-year fellow here at Seattle Children's in clinical informatics. And her fellowship director, Dr. Mike Liu, has served as the founding program director for the University of Washington ACGME accredited Clinical Informatics Fellowship 2015. As fellowship director, he's led our faculty to educate clinical informatics trainees in applied clinical informatics, pediatric informatics needs, improvement science, quality improvement, and most recently, machine learning. And he has arranged faculty meetings exploring diversity in admissions, curriculum review, program goals, and objectives, with new emphases also on faculty and trainee well-being. His expertise is mainly in clinical decision support and evidence-based medicine. He has participated with many of us in the development of over 60 evidence-based clinical pathways at Seattle Children's and described how applied clinical informaticians can adopt and maintain their clinical decision support to ensure proper provision of up-to-date care. Welcome, Dr. Stewart and Dr. Liu. Take it away.
Thanks so much, Dr. Mazur. And good morning, everyone. We're talking today about the UW Clinical Informatics Fellowship and some of the projects that we have done there. Sarah, can you advance the slides? So we do not have any conflicts of interest with what we're presenting today. I am on a study section, and I do have a company that has intellectual property, but it doesn't make any money because we don't sell anything. So our learning objectives today, we would like participants to be able to talk a little bit about some clinical informatics projects such as what we're presenting, understand how it is that we can actually analyze the effect of our clinical informatics projects. And we were talking about not just projects, but also kind of like what was the impact of these projects. And we want to make you aware of some of the different clinical informatics opportunities there are that people might be able to participate in. So first, I'm going to start by talking about our clinical informatics fellowship program. Then we'll talk about some fellow initiated and led projects. And then we'll talk about some future directions for what we're working on. So I think that one of the things that's really challenging for clinical informatics as a field is that a lot of people say clinical informatics, what's that? And so I decided to look at some of the definitions from one of our kind of like our academic homes, which is the American Medical Informatics Association. And so AMIA feels that clinical informatics is a field where we apply technology to deliver healthcare services. And so, the scope of clinical informatics is pretty broad. So, it involves designing electronic systems, implementing those systems, and making sure that people use those systems. And so, clinical informatics is also kind of like a field where, people that practice applied clinical informatics might be folks like chief medical information officers and physician informaticians, such as Rod Tarago when he was here, and now our interim CMIO, Craig Joseph, and also I'm sure you've met a lot of our informaticians. Clinical informatics is a relatively new medical specialty. The very first folks to get board certified in clinical informatics were certified in 2014, so about 7 years ago. And I always view that clinical informatics is a kind of like a process where we can solve problems that are kind of like at not only the intersection of clinical care and technology, but also the third Venn diagram circle would be business. It's really important for the solutions that we provide to sort of like support the healthcare as a business. And I would say that, when you think about what clinical informaticians do, there's kind of like people view that, people have like probably like three different stages for how does this career path has evolved. So when people are in training initially, or probably the role maybe about 20 years ago, and even sometimes now, is just get the system running. So we just went through an epic go live at Seattle Children's, and I think that the 1.0 version of informatics is just please get my system running and have it have some basic functionality working. And I think that the second, level of informatics is really, how do I take the best evidence and put it into our system so that it's really easy to do the right thing and it's really hard to do the wrong thing. And so I think that you guys might have seen that in terms of like the decision support we build for clinical pathways. So, for example, in the bronchiolitis pathway, we might say, okay, for bronchiolitis, we shouldn't do chest x-rays routinely. And so the order set for bronchiolitis doesn't even have a chest x-ray. You have to go and do extra work to make that happen. Whereas, if we are doing other care things like systematic scoring and whatnot, then we can make those nursing protocols part of the order set, and they get ordered automatically when you make a decision that the child has bronchiolitis. And then kind of like the version 3.0 of an informatician is that I think that people are realizing that electronic health records are huge data repositories of clinical information, and they're starting to use that kind of information to, you know, enhance clinician performance. And so, some of the things that we can do with data are we can try to predict, who are the people that are going to develop complications, or, we can improve clinical care. So, one of my fellows had worked on a project to take a look at thyroid imaging and try to figure out if he could improve the performance on which of these thyroid nodules should he biopsy versus leave alone. So I think that with computer vision and some of these other technologies that are within the realm of informatics, I think that we're really looking to improve how it is that we can, make it so that clinicians can provide better medicine and better medical care, where the human plus the computer does a better job than the human might do by themselves. So about our fellowship program, the Clinical Informatics Fellowship Program at University of Washington is a 2-year fellowship program, and we can accept applicants from any residency program. So in addition to training internists and pediatricians, we have also trained an adult endocrinologist, a general surgeon, a pathology / lab medicine resident, and a emergency medicine physician. And so we've had a pretty good diversity in terms of like who we've been able to train in our program, and the pool is even broader. We've seen anesthesiologists, ophthalmologists, and a lot of other medical specialties represented. So our program was ACGME accredited in 2016, and that made us among the earliest people to get accredited. We accept 2 fellows a year, and Zafar Chowdhury has been kind enough to fund one Seattle Children's funded pediatric fellow, and that is Sarah. So that was really fantastic that he allowed us to recruit her. And so kind of like there's 4 main activities that we do in the Clinical Informatics Fellowship. So the biggest activity is kind of like we have our fellows on primary rotations, of which there are 4, and those fellows rotate through these rotations every 3 months. And so, since we usually have 4 to 5 fellows, then, we have good continuity. So if a project lasts more than 3 months, the fellows can just sign them out to the next fellow that's coming onto the rotation. So our 4 rotations, one is ambulatory, where we work on ambulatory electronic health record projects. At UW, that was primarily Epic, and they've had a long history of having Epic around for about 20 years. Inpatient, where probably our biggest activity last year was transitioning from Cerner to Epic at University of Washington. Our enterprise rotation, where we look at kind of like health systems type issues at the enterprise level. So we've been doing things with their Mindscape tool at the University of Washington and retiring that tool, as well as looking at security projects and doing analyses related to machine learning and try to predict high cost patients, readmissions, and looking at other data models that are predictive analytics based that Epic offers, like their sepsis prediction model, for example. And then our last rotation is our priority projects rotation, where we work on projects that are of the highest importance to the enterprise, that are informatics related, and have fellows work on those really hard problems with the support of faculty. And in their second year, fellows can do a 2-month elective in industry as well. And so each fellow typically does about 3 to 5 projects every quarter when they're on rotation. And by the time they graduate, they usually have a project portfolio of about 15 to 20 contemporary um, problems that they've helped to solve. Our fellows also maintain the ability to practice clinically, and so their clinical practice is 10%, about a half a day a week if they're ambulatory, or if they're a hospital provider, 4 weeks a year. And we do provide formal didactics through our master's degree in clinical informatics and patient-centered technologies. That's about 120 lectures that cover topics as diverse as programming, databases, decision support, telemedicine, patient-centered technologies such as apps, and how to design applications using Fire and other newer technologies, sometimes depending on the instructor. And the nursing faculty, so those are taught by our informatics faculty, and we also have nursing faculty who teach about health administration topics and how to design a study, research study, and these types of things. And we also have all our fellows do time do have an experience at Seattle Children's half a day a week, which is informatics continuity. Next slide. So at our informatics continuity experience, it's half a days a week. We do small group teaching, and when we were, before COVID, we actually did this teaching with the clinical effectiveness team in their space. And so, in addition to the journal club that most programs do, this informatics continuity is pretty unique amongst all the programs, as far as I know. So we also teach improvement science, the Institute for Healthcare Improvement based type of approach. In clinical effectiveness, each fellow works on 2 CSW pathways. They help with literature review on one pathway, and they build a decision support for another pathway. So if you use the COVID-19 MISC pathway or acute management pathway, we help to build those. In patient safety, Christina Tancre has come to us during this time and taught us about root cause analysis and failure mode effects analysis, which is actually, the FMEA is actually part of what all clinical informaticians that do the fellowship must learn. We've more recently, over the last 2 to 3 years, been teaching machine learning using Jupyter notebooks and kind of like an experimental setting where we can practice. And typically, our continuous improvement group has helped us with basic courses and more advanced courses related to the Toyota production system. And last year, since we did not have in-person classes in that area, Darren Megida was kind enough to sort of be our sensei and walk us through how to think about lean and things like visual systems and production lines and how to be efficient. And we also do works in progress and practice, and we do talk a bit about how to be effective within organizations. And I think that you can see that a lot of these topics do have huge overlap with the Center for Quality and Patient Safety with Dr. Sherrick and Vanessa Short leading that group. And so we really appreciate that center has really helped our fellows with some of the things they've been learning. So if you happen to see these folks around, then these are our current fellows. We have 3 second-year fellows and 2 first-year fellows. So next, I would like to talk to you about some of the fellow projects that we've had. And so one of our first fellows was interested in how to improve value-based care by changing clinician ordering patterns. And so, I think that that's a question that often happens. It's like when we work in informatics, we actually have to understand, like, what is the change management strategy we want to do? And I think that often people will approach us and they say, well, why don't you do this super easy thing? I'm sure it'll have a great impact. And then we have to like think about it and say, well, do we already know, is this a solved problem, or is this a problem where maybe the easy answer isn't the best answer? And so, the next slide. So one of the ideas that people often bring up to us is, well, maybe we should do cross transparency. Maybe we just put the cost of orders on the orders themselves, and maybe that would make people less likely to order expensive orders. So, sometimes that takes various forms. So sometimes in Epic, they'll say, well, why don't we do the $1 sign to $4 sign for cheap to expensive tests? And, there is actually studies that have been done at other places by people like Dr. Chen, where they've done things like they put imaging study prices on the imaging study orders. So if you try to order a brain MRI, it would say in that study, oh, that's a $778 test. Are you sure you want to, but it's passive. It doesn't ask you, are you sure you want to do that? It just shows you that how much it costs. Well, unfortunately, simple interventions like price transparency, like in that simple format, really don't work. I think that there have been many studies, and a systematic review examined about 12 of those studies, and I would say that most of the studies show that that kind of process doesn't actually make any difference at all in terms of ordering. Although, there are some studies that suggest that maybe over the short term, for a month or two, it might make some small effect, but then that effect is washed out over time. So there's not really, effect of using price transparency that is sustained. That intervention is a little bit too weak to actually cause physician change behavior. So another thing that we tried as well, can we actually do change behavior? And so actually, at the lab at UW, they had actually introduced a couple of lab orders. They'd renamed lab orders to vitamin D 125OH level and the vitamin D 25OH level. And they found that when they put them in the order catalog, it's like people really didn't know which of these orders to order. And so they decided to change the name of the order, which is a similar type of a concept, pretty easy to do. So they could say, okay, well, if you want to do the common vitamin D level looking for deficiency, or the vitamin D 25OH common deficiency level order. And if you're looking for an endocrine disorder, then you can order the vitamin D rare 125OH endocrine disorder lab. And they wanted to see if that would improve people ordering the correct vitamin D 25OH deficiency level order for looking for vitamin deficiency. And they succeeded. So this was actually a study done at UW. First author was Andrew White, who is working with our fellows, and Paul Sutton, some of you might know for various reasons. And so they had a very nice result where they showed that this name change actually did have a significant impact on making it so that they were ordering the correct test and you were not ordering the incorrect, infrequently used test. And so they concluded that changing names of orders could reduce unintentional overuse of infrequently used tests. So the next thing that they examined, the next thing that we studied, so this was our fellows scholarly project. He was wondering if target alerts could change behavior. And so he created this more active clinical decision support that was very targeted, though. So if you tried to order a high cost medication like clobetasol propionate, it would actually pop up something that says, that medication is more expensive than the available alternatives. It costs $165 a tube instead of $71. When you're using ultra high potency steroids, you might use betamethasone instead. And then actually it provided you with the, kind of like clinical decision support should be to the right person at the right place at the right time in the workflow, et cetera, et cetera. Actually, you could just click on the betamethasone order that you wanted and it would immediately substitute it versus you could click on continue the original order. And he found that that type of very targeted clinical decision support was successful. They did a randomized pilot with 4 high-cost medications, and they found that there was about a 1/3 decrease in the clobetasol, and even more for doxycycline, and still about 43% for fluoxetine. But for using high-cost triptans for migraine and whatnot, there was only a 3% decrease. And so for these 4 medications that they piloted, the overall decrease in prescription of high cost medications was 32%, with an estimated savings of $127,000 per year just for those 4 medications. And I got to say that I think that the hope would be that if we did that, that would be savings to the health system. But I think that probably the benefit of that might have accrued mainly to payers. So I think that's also a challenge with our informatics work. So the second project I want to tell you a little bit about is a project that where we were looking at population health with ambulatory care pathways. And this is a project that actually spanned almost 2 years of fellow time, which, as I was mentioning, it's like, so they were working on the ambulatory and in the priority projects rotations, and then they could sign out those where their progress to the next fellow type of a concept. And so I think that people at Seattle Children's are pretty familiar with the idea with CSW pathways that standardizing the approach to medicine might improve clinical quality and improve the ability of the whole care team to kind of like know what's going on, and so care is more efficient. And so, you know, some of the components of CSW pathway that you might be familiar with, there's a PDF of an algorithm, which is kind of like a flow chart that tells you kind of like what is your decision support. And these are the visible tools. Obviously, there's also the evidence review that happens before that. Clinical decision support to make it so that the algorithm's recommendations can be followed more easily. There's some way to identify patients who are on a pathway, so you can, and then you can analyze clinical performance of patients on our pathway based on tools that are in our enterprise data warehouse. And so, in addition to those basic tools, I think that there's a slightly different spin when we were doing these projects at UW. Um, so, one of the pathways we were looking at, which I'm going to talk more about, was depression. And so, for depression, it's like they have a screening tool, which is the PHQ-2 to PHQ-9 2 or 9 question screening tool for depression. And so that's kind of like patient entered data in the best sense. And so that's kind of like some patient reported outcomes. And then the way that they track things in Epic in the ambulatory space is that you can actually take your patients, put them together, and collect them into something called a registry, which then you can actually use which is kind of like a population health tool, which can be used to look at patients in aggregate and how their outcomes are doing. And then one of the innovations we also had was the clinical care path tool, which I'll talk about. So over a 2-year span, fellows are involved in helping to create ambulatory care pathways for depression, hypertension, and diabetes in adults. And most of our examples are from the depression care pathway. So I got to say that depression was one of the first ambulatory care pathways that UW Medicine developed. And you can see that the initial algorithm they had for the depression pathway was extremely complicated. And so the fellows and I did take a look at that, and we sort of applied some standardized approaches for how to understand state of patients, and we were able to simplify that algorithm dramatically, getting rid of about 40% of the boxes, so that you can see the end result was kind of like a more comprehensible standard of care. And then we developed clinical decision support. So I think that one of the things that I'd like to emphasize about the decision support at UW as compared to what we're used to at Seattle Children's is that so some of the things are similar that we modeled based on the pathways here. So as you can see at the very top, or maybe you can't see because it's kind of small, you have your depression pathway order set, but underneath it, there is a depression care pathway hyperlink that takes you to the algorithm. So we have that at Children's. But the next, there's actually documentation templates that were designed specifically to support documentation needs from the pathway. So you can see that the next section, there's charting tools. There are the depression pathway initial template, the depression pathway follow-up template that you can click on, and then you can actually create a note very specific to that diagnosis quickly. And I got to say that it is challenging because I think that at UW are the patients that are adults have a lot of comorbidities, and so sometimes it's like we do those also with kind of like smart phrases or dot phrases that we bring in. But for patients that don't have a lot of comorbidities, those notes can also be pretty helpful, or if it's a focus visit. And then you can see that you can just click on patient instructions, and those are automatically added to the kind of like the after visit summary without additional consternation and having to look things up. So those are some of the things. But the other thing that's really nice about the way that we could design things in Epic is that we were able to take advantage of, you know, these little kind of like fold outs. So you can sort of see that the outpatient prescriptions for first line antidepressants, by default, when you order this order set, it is folded out, and you can see like what are the recommended first line medications, and you can see those radio buttons where you just choose one of those. But then if you want to go on to second line antidepressants, you could just fold out that next tab, and it would just show you what the second line things are. You can sort of see above those prescriptions also, there's kind of like built-in decision aids that are easily accessible within the EMR. So you can sort of see, there's a UW depression pathway, kind of like standard therapy recommendations. There's also a Mayo Clinic shared decision-making tool where you can get more information about the patient, and you can choose your antidepressant based on patient-specific characteristics. And so then in the upper right, you can sort of see that based on what the patient's PHQ-9 score is, you can really determine like kind of like, you can fold out and do the right thing based on how severe their depression and then you can also bill appropriately for kind of like what it is that office visit is. Next. And so the other thing that was kind of new a few years ago was that, we didn't really, the way that they used to do this kind of depression screening is that the patients would fill out this form on paper, and then it would be entered into an instrument or some kind of flow sheet. And so we actually did build like a smarter form that corresponded to the PHQ-9 screening form directly into the rooming tab for our medical assistants. So you can see there's the first two questions for the PHQ-2, and if the score is high enough, then that'll actually full out into a full PHQ-9 assessment. And then, and since we were building this ourselves, we were actually able to add things that would make it easier for our own analysis performance. So we did have a question at the bottom that says, does your patient primarily receive their behavioral health or psychiatric care outside of UW medicine? And so if these patients were not really being managed for this by UW medicine, then we could exclude those folks from our pathway registry and analysis. And I think that the other thing that was really great is that this served as a basis for improvement where eventually I believe we did manage to sort out how we could push this out as a patient survey in the eCare portal that patients could fill out before their visit electronically, and then that information would be integrated in a way that providers could see the results in Epic. And so the next thing that we did was, so UW was among the first Epic installations to actually use the Care Path tool. And so care paths allow clinicians to identify patients for pathway-based care, and they can do that in an automated way most of the time. You can review kind of like how is the treatment going and where patients are in their treatment, and then you can target your decision support based on kind of like which box on the algorithm are you at. So one of the things that is pretty exciting about the care paths is that for identifying pathway patients is that patients can be started on the pathway in one of three ways. Automatically, they can, so for all patients that are adults that have a PHQ-9 score greater than 9 and have a depression diagnosis on the encounter on the problem list, they automatically get added to the pathway, or a provider can add those patients manually. Next. And then you can see visually that they're on a care path. They created an episode of care where you can look at all the encounters that relate to that the diagnosis. Next. And then you can see that the care path is a visual representation of where you are. So, here you can see that if a patient has a moderately severe PHQ-9 score, they can automatically be added to the care path, and then it will automatically take them to the next step, which is to titrate the medications to their usable therapeutic dose. Next. And then you can see that based on where you are, on which bubble you're on the pathway, you can either be on step 1, where it tells you to start a first-line medication, step 2, where you might consider a second-line medication, or step 3, where you should make a referral to the behavioral health intervention program or to psychiatry. Next. And so one of the things that they work on with these care paths is that those diagnoses had like a difference in performance between where we wanted to be and like having everybody get that right care, and they call those things care gaps in the adult world. And so our care gap closure performance did improve from 2017 through 2018 and 19. And so, but through 18 with the measures. And then one of the things that was really exciting was with the hypertension care path that the system automatically enrolled nearly 105,000 patients to make sure that they got their blood pressure rechecked when necessary and started on the right treatment plan. And roughly 5% more patients than was expected from previous were actually, normotensive based on the pilot studies, and that would have an expected effect of having decreased heart attacks, strokes, and dementia. Next. And so the last fellow project I want to tell you about before handing off to Sarah is a research project in how to identify more patients for lung cancer screening. Next. And so UW Medicine has been working on improving rates of lung cancer screening. And so per the U.S. Preventive Services Task Force, clinicians should order a low-dose chest CT every year for patients that are between 50 and 80 they have a 20-pack year smoking history, and they quit within the last 15 years, or they are currently smoking. And that kind of screening has led to about a 20% reduction in lung cancer mortality based on large studies. And the problem is that in the electronic health record, we do have in Epic a smoking history section and kind of like the social history section. And if you fill that out, then provides discrete data that can be used. However, that's inconsistently filled out. Next. So one of our fellows did do kind of like a research project where they looked at 5,500 patients that did have kind of like an unknown or an incomplete smoking history in that component. And then they created an algorithm. He created an algorithm based on regular expressions to process that text to figure out pack years and figure out when they stopped smoking. And he did find about 20% of those patients did meet criteria for lung cancer screening. And the potential impact of finding 1,000 people is that you would potentially be able to find 4 people that you could actually save their life for. And so I think this is kind of an example where data scientists are always talking about how it is that data science saves lives. This is kind of like a project that could do that. And I think that if we did, instead of using some kind of regular expression analysis, we could use natural language processing, we could probably identify even more patients for screening. So with that, I'm going to transition to Sarah.
Great. Thank you, Mike. My name is Sarah. I am a second-year clinical informatics fellow funded by Seattle Children's. And I work jointly both at University of Washington and Seattle Children's on my informatics work. Like Mike said, when people find out that I'm an informatics fellow, they often ask, what does that mean? And like, what do you do every day? So I thought I'd walk you briefly through what I do in a week's time. So first, I'm enrolled in master's degree courses, like Mike mentioned, through the UW Clinical Informatics and Patient-Centered Care, Patient-Centered Technologies program. I take classes virtually with my other co-fellows and other nursing students, and the topics range from database concepts and applications to telehealth systems to conceptual foundations for healthcare systems. And we're learning a lot of really great things through projects in those courses. Then I spend a half a day over at the Roosevelt Pediatric Clinic, precepting the pediatric residents over there, which is a lot of fun. Some of my co-fellows work in hospitalist roles at University of Washington or Harborview, and they do about a week's worth of service per quarter. Like Mike said, we've had surgeons and pathologists, emergency room physicians, and they've all worked out various clinical time through their fellowship. And then the rest of my days, I'm on one of 4 rotations, working on about 3 to 5 projects per quarter, having to do with project-based learning, and that's both at Children's and at University of Washington. So that's a little bit about what I'm doing every day. Next, I wanted to focus on one of the projects that I worked on last year, improving clinician efficiency by redesigning the documentation templates. So this was an ambitious project taken on by the physician informatics group over at University of Washington. As you guys might know, for those of you that rotate over there, they similarly went from Cerner to Epic for their EHR, and we called this project the D1 project over at UW. And we wanted to redo and deliver a new set of documentation templates for our providers as we move from Cerner to Epic. So we started with about 70 separate specialty note templates. There wasn't really any internal or external consistency. Some note templates were shared between people within a service line. Others were using very basic note templates. It really varied from really individual to individual what was being used. Our group of our team was 4 informatics faculty and 5 informatics fellows. We were all Epic physician builders. And our official mission was to improve clinician satisfaction by decreasing time to document. And just as a little visual, you can see our 5 fellows from last year listed at the bottom. Underneath, I've included each service line or division that that fellow worked with to design their note templates. As the pediatrician in the group, I got to work closely with the nursery and the NICU team, as well as the pediatric and PICU team over at Harborview to create the pediatric specific note templates. Generally, we created about 4 templates per division. So an H&P note, a progress note, a discharge note, and a consult note. Some services had some additional needs. And some services decided that they were going to take a generic standard template that we also created and didn't need any specialization for their particular group. I wanted to talk a bit about the process of this project. The first step was gathering a team of important stakeholders. So colleagues from the health information management team, colleagues from compliance, our physician and APP subject matter experts. So that was about 1 to 2 providers per division or service line that gave us input on what they needed as a group. And then our clinical informatics physician builders. This group was really key to our success. Having HIM and compliance on board from the beginning of our process was ensured that we were on the right track in terms of their needs. And when we came to the end of the project and we had our note templates complete, we had a very smooth review process through both HIM and compliance. So we started with the prior note templates from ORCA, which was the previous EHR, the Cerner system. Like I said, about 70 different notes. And the timeline looked a little bit like this. We gathered all of the best practices from literature and from talking to other EPIC institutions about documentation templates. Then we spent about 3 months decomposing those other prior note templates that they were currently using and meeting with those APP and physician subject matter experts for each division. And then we had a very rapid build, completing all of our note templates. There are around 100 unique note templates, about 150 total note templates in just 2 months of build. I wanted to show you kind of a before and after of what these note templates look like. This is a little bit small to read, I know, but this is one of the nursery note templates from Cerner prior to our project. So gives you some basic information, maternal history, delivery information. We of course have our physical exam, a brief laboratory section for maternal labs, and then our assessment and plan. This note was primarily manual data entry for this information, as well as some phrases that were automatically pulled in, like physical exam and the assessment and plan. Here is a look at one of our nursery H&P notes after our project. So first, you can tell the font is smaller, so the note is a little bit longer. That is definitely the case. I am going to go into a little more detail on some of the sections in a moment, but I wanted to highlight some things here on this screen. So one of the strategies we took in our note project was we wanted some standardization across notes. One way we did that was creating modular components that were shared across multiple notes. So you can see this darker purple area in the upper left corner is our header module, and this
I don't know how to get it to stop playing.
in the
Because it's about, this is one.
in the upper left corner, we have the header, and this is shared among all note templates throughout University of Washington that we created. And it allows us to make changes to one section if we needed to add something to that section and also have that standardization, like I said. So here we have preferred name shown in every note template. And when you look at any of these note templates, you know exactly what you're going to find in that one section. Some other highlights of this note template. We are pulling in a ton of this data automatically, and we have a really cool link between the mom's chart and the baby's chart, because at University of Washington, most of our babies are delivered there. We're able to have this link and pull the information directly from mom's chart into the baby's chart straight into your note. At Children's, unfortunately, our babies are all outborn, so we don't have that connection. But it's saved a lot of manual data entry time for our residents and the rest of our providers. We can then, you've probably routinely seen some of this at Children's now with Epic, pull in our weight percentiles. So very quickly while you're writing your note, you know if you're looking at an appropriate, a small or a large baby. We can look at the initial vitals and then the most recent vitals, and then of course the physical exam and the assessment and plan. So I wanted to take a closer look at the maternal history and lab section. This is a section that I spent a lot of time on as I was building this note. The prior note showed the brief maternal history that you manually input, and then a very brief lab section for maternal labs. On the right, you can see what I've put in the nursery note template, and we also have a similar in the NICU. This is pulling in a mom's information straight from her chart. So what are her G's and P's, her estimated due date, and then her labs for the last year. You can pull in her blood type, all of those labs that you really want to just make sure you review quickly, don't see any red flags, and can move on. Instead of digging through the chart, you have it right in line as you're preparing your H&P for the day. The blue highlighting means that these are refreshable links, smart links. So if this information wasn't present initially, the OBs were manually putting in that information on their end because the patient was seen somewhere else before they came and delivered. I can refresh my note and it'll pull in if new information arises. This is another section I wanted to highlight, the delivery information. Again, beforehand, a lot of manual entry. Now, that data, it does have to be entered into the note or into the chart. It's typically done by a nurse or a delivery nursing assistant at the time of delivery into the mother's note, and then lives in this document that sits between the baby and the mom's chart called the delivery summary, and pulls in the important information straight into the note template. I want to highlight right here this hyperlink you can see. I'm going to talk about that in a little bit, but basically if you click on that, it'll pull up that delivery summary I was just talking about, and you can review that data for yourself in line as you're writing the note. So I want to discuss some of the note features that we used in our documentation optimization project that really highlighted some of Epic's key functionality that we didn't have with Cerner that really, we think, enhanced our note writing process. So those refreshable smart links I discussed, the blue highlighted text in the last screen allows you to pull data from really all over the chart, from mom's chart, from the delivery summary, from flow sheets, from patient entered data like Mike was discussing earlier, from online questionnaires. Really, if there's data entered in the chart, we can figure out how to pull that into the note automatically for you. We also did this neat thing with collapsible sections. So probably a lot of you are familiar with the concept of a SOAP note. That's how most of us were taught to write notes. In medical school, you talk about the subjective, the objective, and then the assessment and plan. There's a movement towards a APSO note. So having the assessment and plan first, followed by the subjective and objective. Because oftentimes when you're going into a patient's note, you really want to know what that provider determined was the assessment and what they want to do for this patient. And you don't necessarily need that other information when you're just taking a quick glance at the note. So that would be a big jump to switch everyone over to that APSO format right away. So we decided that we would take advantage of Epic's collapsible sections, and automatically we have the subjective and the objective collapsed so that when you open a note, your eye is drawn to the assessment and plan at the end. Some people might say, oh my gosh, that wouldn't work for me. I want to see it all. I want to see, I'm used to this. This is the way I like it. Not to worry. You can change your default so that they are expanded whenever you open a note. But the first time you open a note like this, you are going to see them collapsed at UW. Some other benefits of our project, we really focused on standardization. We wanted to make sure that those notes looked similar across specialties and between specialties, really so that a resident rotating between different services would have a similar experience. But also so that the reader of the notes knew where to look to find things. Whether you're looking at the pulmonology consult note or the GI consult note for your patient, they're going to look and feel pretty similar, but have the necessary information that those services need to provide the information on their patients. But hopefully it's going to decrease some of that mental burden when you're reviewing notes as a reader. I discussed the modularization with that header section in the nursery note. We have lots of modular sections that we share, especially among the other medicine documentation templates. It really helps with that standardization, but it also helps with a more technical side with the build maintenance. So as an example, here is a lab table that it's found in a lot of our progress notes. As you can tell, it's more geared towards adults. We have D-dimers and BNPs and anti-10As. We don't routinely do that on all of our inpatients, or at least hopefully we aren't over at Children's. But we're able to make changes just to this one file. If, say, one of these labs changed and the name of the lab changed on the back end, we could just make one update, and that's going to be reflected in all of our note templates without having to go through each one. We also are using a similar a lab section in our nursery and NICU notes, but we've adapted some of these labs to just be relevant to those babies. Same with the PICU and the pediatric floor patients over at Harborview. Another we think really cool tool that we're using in our note templates are called vanishing tips. And if you have rotated over at UW since Go Live, you're probably very familiar with them by now. They are a really neat way to allow interactive note writing. So they are these sections of, they can be links to other parts of the chart for chart navigation. They can be links to external hyperlinks. Like, for example, you could link out to the Billy tool, or they can provide just-in-time education. But the key is that they are present when you're writing the note, but when you sign the note, they disappear. So they're not adding anything to the note documentation length, and they're not creating clutter. They won't be part of the patient's record after you've signed the note, but they can provide the note writer with assistance in real time while they're writing the note. So here are a few examples, like the delivery summary link I mentioned earlier in the nursery note. We can link to the growth chart. You're going through your vitals and you're like, oh, I want to see the growth chart, but I can't remember the fastest way to get there. Just click on that link, it pops it up, review it, looks good, you can exit out. Labs, specifically, I want to see the glucoses on this patient. The nurse, the NICU babies can click on that, will pop up the relevant information. Here is a quick visual. This is providing some reminder, some just-in-time education. Don't forget to update and review the allergies. You're like, oh yeah, I need to do that. Click on that hyperlink on the left. You can see it's pulled up the allergy tab. You can review that, and then you can move on. You're done with that part. As an example of providing just-in-time education, in our COVID ambulatory note template, we were able to provide information to the provider about testing for COVID. As recommendations changed, we were able to update this information. The provider didn't have to go externally to find the latest up-to-date recommendations at University of Washington. They knew that it would be in the COVID note template. And again, that disappears when they sign the note. Another project that we took on with our documentation project was standardizing the attestation process. At UW, there are more than 50,000 attestations a year. Prior to this project, there was no standardization. People often created their own phrases for attestation, and some of them unfortunately did not meet compliance. Through this documentation optimization process, we created a core set of attestations that met all of the providers' needs, from surgical, procedural, to ambulatory, to inpatient. The way that we built it using they're called smart data elements, allows us to track these attestations over time and determine how many procedure attestations are being used, or E&M, and how often certain options are chosen, so that we can make changes, delete things that people aren't using, or add things that people are adding in. And importantly, since we were doing this with our compliance folks, all of our attestation statements all meet compliance requirements. So here you can see just an example. You're selecting from these smart lists. It's giving you options. Quickly go through that, and you have your attestation statement. Another great feature of our new documentation structure is the ease at which we can make systematic changes. So, for example, with the new 2021 CMS E&M requirements, we were able to modify our ambulatory SOAP note to reflect the simplified documentation requirements, which only require that you document that you've reviewed history instead of actually documenting the full history of specific sections in your note. So we provide the option. You can pull in all of those history sections into your note if you want, if you choose this first option, or you can if you choose the second option, or you can choose the first option and pull in the history review statement. And so here's an example of that at the bottom. It will say, I have reviewed, and then you choose what sections you reviewed with the patient, just to make sure that you have quick access to those sections. There are the hyperlinks, and you can review those with the patient. And when you're done, you sign that. It's going to only be 2 lines long, saying that you've reviewed histories. We were able to make these changes really rapidly because we have control over the note templates. This is another part of those E&M requirements. We're able to use these checkboxes so that you can document that you reviewed labs and imaging without having to pull in all of those results directly into your note. I also wanted to touch on the outcomes of this documentation process. So first of all, I've discussed standardization a lot. It's made documentation writing and reading easier for our providers over at University of Washington. The other tangible benefit is time saved, and this was one of our goals. So we did some user observations both before we made these changes. So when people were still using the prior EHR Orca, and after we went live with UW, with the Epic at UW, you can see on this table, residents in the nursery were spending about 30 minutes writing H&Ps and discharge summaries, and 15 to 20 writing the daily progress notes. After we implemented this, those changed to 10 to 15 minutes and 3 to 5 minutes. Doing some calculations based off of the number of babies that are in the nursery per month at University of Washington, Montlake, and Northwest, we estimate that we saved at least 56 hours per month in resident documentation in the nursery alone. And those are our pediatric residents over there. So we're pretty happy with that, and it turns out the residents were happy too. Here are some quotes. People love the new templates. They're way easier to write. They take less than 10 minutes. I love that all the mom's information is already in the notes. From the PCP standpoint, so residents looking at these babies' notes when they see them in clinic, they're much easier to find the information they need because of the standardization. So I wanted to discuss a little bit about the future work that we're doing in the Informatics Fellowship program, both at Seattle Children's and UW. Right now, I'm involved in a optimization project over at Children's, where we are focusing on division-based provider usage data using an Epic tool called Signal, as well as direct observations to figure out what part of the EHR, what part of Epic we can change to make it better for you guys as providers at or at Children's. We're also in the process of moving our external code sheet that sits on the desktop in Excel into Epic, which will be an improvement. And over at UW, we are working hard to get adolescent MyChart access. We are updating some of our order sets in the ambulatory setting. We're integrating a substance abuse screening tool for trauma patients over at Harborview, pediatric trauma patients. And we are we're becoming more involved in work related to equity, diversity, and inclusion as well. How to connect with us. I wanted to make sure to give you our contact information. Both Mike and myself, our UW email addresses. Please contact us if you are a resident or fellow and you want to be part of the resident and fellow IT committee. I chair that. We meet once a month and discuss various informatics related topics. If you want to learn more about the fellowship or doing an elective as a fellow or resident, please reach out to us. If you want to involve informatics in a project you're working on, or you want to get involved with the informatics project we're working on, please, we're happy to chat. We have lots of people we like to acknowledge, a lot of help to make these projects work. And then I wanted to shift over to questions.
Thank you so much. For everyone who's on the line with us, you can enter any questions or comments into the chat, or if you feel brave enough today, you can unmute yourself and even turn your camera on to ask a question in person. We have about 5 minutes for questions. Thank you so much. From Dr. Marshall, so appreciated the great overview of clinical informatics and the fellowship. Fascinating to learn about the work that's being done broadly and specifically by the fellows. Great to hear about the outcomes and future directions. Thanks for the great presentation to you both. Thank you, and thanks, Dr. Marshall.
Thanks.
I'll wait about another minute and then we can let everybody get back to their Thursday. We really appreciate you too for being here and for all the work that you're doing, especially with our big transition this year. It's made everything so much nicer. And so we really appreciate your help.
Hi, this is Glenn Tamora. I have a quick question. So one concern I have about, first of all, it's a great presentation. That's really fantastic. I worry a little bit about blowing in data, because if people are spending very little time on the note, are they actually looking at the data and processing it? Because obviously when you have to enter it all manually, you have to think about every single piece of data you're putting in. So have we looked at how often people miss clinical data because they're just not looking at it, it's just blown in there?
So I guess I would say that we haven't systematically looked at that question that you're asking, but I think that it's kind of interesting because I almost think that in some of the experiences that I've seen and observed, that it's kind of the other way, that if you don't make it easy for people to access the data, then then they have to go out and look for it, and it takes them more effort to look for it. So it's kind of like we want to make it easier to do the right thing. And so I do think that there is some admittedly anecdotal, like when I'm on service, I think that the residents like it when we bring things in, like what were the vital sign ranges, because then they don't have to go to the flow sheet and figure out what all the vital sign ranges are. And I don't think it makes it less likely that they're going to have the up-to-date information about the vital sign ranges, I think it's more likely they're going to have that type of information. So I think that for things that it's really critical where you want to know, what was the GBS status of the mom, and that's available to you quickly and in your workflow, I would hypothesize that for some of that information, and probably, making it easier to get the information quickly is probably going to be helpful from a information access point of view, but it hasn't been studied, so I can't prove that conclusively.
Thank you. And our time is up, but we do have 2 more questions. Maybe we can address them quickly. From Suzanne, thank you for this enlightening presentation on the valuable work, oh boy, that you have been involved with. I wonder how this has improved resident well-being as well, and how this might be measured. Also interested to learn how health equity diversity will be included in this work. Just a quick question, and also any chance of sharing note templates community pediatricians who use a different instance of EPIC, e.g. Providence EPIC.
Yeah, so I guess, is this okay if I take these 2 quickly, Sarah?
Yes, Mike. Yep.
Okay, so I think that the as far as the improve resident well-being, so we actually do have a well-being committee that's in our IT governance at UW, and also an education committee, and we are going to be looking specifically, just as Sarah was talking about, we've piloted at Children's at UW. We're going to start looking at how are things like pajama time and time spent outside of hours and other things, how might they relate to well-being, and how might we be able to identify people a little bit earlier that might benefit from resilience training or whatever interventions we want to do. And so that's a work in progress, and if that's something you're interested in, please contact me, because we are looking for people on that governance committee. And for health equity and diversity, UW has Patients Are First goals, where we take a look at cancer screening and these types of things. And over the last year, we have finally started doing sub-analyses related to race and ethnicity and socioeconomic status and things like that. And we are, examining that data and trying to figure out how we can create interventions to improve equity. And as far as like sharing note templates with other institutions, we do have contacts with CMIOs across the region. And if that's something you're super interested in having them pursue, then please send me a note, and I can try to make that bridge, and we can see if we can share some of that information.
Great. Thank you so much. Thanks, Dr. Stewart and Dr. Liu. We really appreciate your time and all your hard work. And thank you, everyone, for being here. And we'll see you all next week. Thanks, guys.
Thanks, everyone.
Thank you.
Have a good day.